Hello, everyone. I'm Brad Folley, and I'm at the Norton Neuroscience Institute in Louisville, Kentucky. I'm a neuropsychologist on staff here. And what I do is assess patients and treat them for memory problems and other cognitive disorders that come with medical conditions like Parkinson's disease. And so I've been asked today to talk about memory and Parkinson's. And I've been in the community for a bit, probably 11 years, and I'm sure some of you may have met me or know me. And unfortunately, we're doing this virtually today, so I can't really take questions, but I'm hoping to give you a meaningful presentation that will answer some of your questions in advance. So they asked me to speak today on, does Parkinson's disease impact memory? And before I give you this talk, I'm sure everyone knows the answer to that question. The answer is, of course, yes, it does impact memory. So what I'd like to do is go through some of the factors that affect memory in Parkinson's disease, because they're not all obvious. And also, I have to tell you honestly that when I say memory, it might not be the same thing that you're talking about. So I also want to define memory. And I wanted to talk about some of the features that can affect it in Parkinson's. And in the end, kind of what those clinical conditions are and what we can do about it. So can Parkinson's disease affect memory? Of course, the short answer is yes, it can. It probably will in some form or factor, but it's important to understand how. And so those are the basic questions of this talk. It can, how can it? It probably will, how will it? And how does that process happen? 97% of patients with Parkinson's will experience non-motor symptoms related to their disease. One of those non-motor symptoms, we're not talking about tremor, rigidity, slowing of motor function. We're actually talking about changes in cognition or changes in mood. So keep in mind, memory is directly affected by other underlying sources, okay? Age, we're not expected to remember as much when we're 60, 70, 80 as we are when we are at our peak. And people sometimes overestimate that. Our peak is actually in our early 20s. So if you can remember that period in your life, that was the peak of memory performance, and it's actually all downhill from there. So age is a large factor, especially as individuals who are diagnosed with Parkinson's disease are diagnosed at an older age, because the age decline that we consider normal is overlaid on the Parkinson's issues as well. The disease itself, so those areas of the brain affected by the disease, if those are involved some way in memory, they won't work as well. As the disease progresses and you get more and more medication, or medications are changed, those perturbations in those neurotransmitter systems will also cause possible effects on your memory. Related cognitive factors. When we talk about memory, the disorder or the dysfunction doesn't always have to be in memory itself. So if you have an attention problem, people always tell me I can't remember. A lot of times they're just not paying attention well and they're not realizing it. Or as part of Parkinson's, your processing speed declines. The amount of time it takes to take information from the environment, put it in your brain, make a decision, and then spit out an answer can actually be very slowed. And when that's slowed, your timing that you've been used to your whole life is much slower. And that causes a process called delayed consolidation. And our memories take much longer to form, and we're not used to that timing difference. And so those factors are related as well. The other part that's important to remember is mood. Mood affects memory, mood affects attention. In particular, depression, which is very common in Parkinson's, and anxiety, both of those things can eat up your cognitive resources. So your brain has only so much money in the bank it can spend, and if it's spending it on those things, it doesn't have a lot to spend on actual memory and attention processes. So just keep those in mind, because I'm going to talk about direct biological effects that Parkinson's has down the road to affect memory, but it's not always such an easy answer. Parkinson's itself is related to alpha-synuclein. It's a protein. It deposits in the brain, in areas of the brain. And when it does that, it causes dysfunction in those cells. Those cells don't work anymore. In particular, we're talking about dopamine and acetylcholine and the balance between those two. Those are the chemicals that affect the cells in the brain in Parkinson's that we're interested in. And I'm going to get into a little bit more of that. We always think of Parkinson's as a movement disorder, which it is, but it also affects your thinking and your mood. That will downstream affect your role, the things that you're used to doing, who you are in your life, and changes in your relationship with significant others, loss in quality of life, embarrassment, not wanting people to see the symptoms, and restriction of function. Let's define memory. What's memory? It's not just, can I remember what happened to me when I was 13? Memory is divided into many factors. Sensory memory is the first type of memory. It's quick, it's fast, it lasts under a second. It's things that you see, hear, touch, smell, taste in the environment. If you decide to pay attention to it, we call that selective attention. If you decide to pay attention to it, you're able to then process this as a short-term memory. If you don't give it attention, it's gone. It's out of your reach. And if it happened and you didn't give it selective attention, you didn't pay attention to it, you'll never remember it happened because it didn't go in your brain. Once things are processed into short-term memory, this short-term memory is a temporary, limited capacity storage source, where if you don't transfer it to long-term memory through a process called rehearsal, it will also be lost. And so the long-term memories are usually what we're talking about in terms of those permanent memories that we have about information, about events in our life, about how to do things, but not the short-term memory, which in my mind is not just memory for yesterday. Memory for yesterday is actually long-term memory. But short-term memory includes things like working memory, remembering a phone number before you can write it down, those types of things that are gone as soon as you stop rehearsing them. Once you've rehearsed them and they go into long-term memory, different factors affect how you can pull them out and how they're stored. Once we get into long-term memory has different varieties. And sometimes we don't appreciate these. But I can tell you that what most people tell me as consider memory are things like episodic memory. Okay, so in terms of long-term memory, we have explicit memories, those things that we consciously recall, and implicit memories, those things that we don't consciously recall, we just remember them. And those include things like what we call procedural memory, memory for how to do things, how to ride a bike, how to go skiing, how to brush our teeth, motor skills and habits. We don't really consciously think to ourselves, I need to go remember how to brush my teeth. We just pick up the toothbrush and do it. Other things that are explicit are semantic and episodic memories. Semantic memory just means your knowledge about the world, things that you learn. The capital of the United States. What temperature does water freeze? All of this type of stuff is considered general knowledge, semantic memory, but it's a form of memory. It's something you learned and you have to recall it to use it. Episodic memory are those kind of pictures in our head, personal experiences, things that happened, events that happened in a certain time, a certain place. And in different disease processes, these different types of memory are affected differently. So for instance, in normal aging, semantic memory, our knowledge is pretty well preserved, where episodic memory is something that is more prone to dysfunction. And certainly in Parkinson's disease, there are different effects on these memories than in other processes like aging or Alzheimer's disease. So these cognitive functions that affect memory, not just memory, include things like our executive functioning, planning, decision-making, working memory, that ability to keep the phone number in your mind until you can write it down, being flexible, inhibiting, using your attention processes to decide what's important and not important. All of that is dependent to a large part on a chemical in the brain called dopamine, which we know is the chemical in Parkinson's that doesn't work very well. We also know that acetylcholine, which is the memory neurotransmitter that's most affected in Alzheimer's disease, is affected in Parkinson's. It's just in a different way. And the way is a balance, and I'm going to talk about that. Dopamine is actually converted into other neurotransmitters called the noradrenergic transmitters. Those are epinephrine, norepinephrine, and those are involved heavily in attention and processing speed. So you need all of these things. You need to plan and be flexible and open your working memory. You need to sustain your attention and select in order to form memories later on. And so all of these things are intertwined. The oversimplified model, if you're following along, is that dopamine affects those executive symptoms like planning, inhibiting, allowing you to make good judgments and things like that. Acetylcholine, the cholinergic deficits, are really involved in the cells that process memories. Noradrenergic deficits, those are attentional problems. And we didn't talk a lot about this, but serotonin is highly involved in mood, and that's also affected in Parkinson's disease. So it's not just about dopamine. Different areas of the brain are selectively important in those functions as well. So the amygdala and hippocampus are very much important structures in relating information from short-term memory to long-term memory. And areas in the frontal part of the brain and back here in the cerebellum regulate the timing of our memories and the input-output of those memories. I'm sure you've seen this slide many times, but in the brain, down in the brainstem, so down in our neck area, in the lower part of the brain, there's an area called the substantia nigra. It means the black substance. That's where the dopaminergic cells make dopamine and then send that dopamine out to other parts of the brain in three kind of tracks where they send that dopamine out to the brain. In Parkinson's disease, you can see that there's decreased black substance, which means that those cells are not really there anymore. And you don't start to feel the symptoms of Parkinson's until about 80% of those are gone. They're gone because of alpha-synuclein, which is a protein that deposits and causes these things called Lewy bodies. And yes, there is a dementia called Lewy body dementia, and it's related to Parkinson's disease, but Parkinson's is a problem in the alpha-synuclein deposition that causes Lewy bodies. So there's a relationship between Lewy body disease and Parkinson's, and we think it's actually depends on where that deposits in the brain. Parkinson's staging. Over time, Parkinson's starts in the brainstem and works its way up. So depending on what part of the brain is involved in Parkinson's, whatever part of that part of the brain that's controlling attention or processing speed or encoding of long-term memories, if the Parkinson's disease process has moved into there, you'll get more problems with those functions in the brain. You can see here the pathways, which are dopamine in blue, acetylcholine, remember that's the memory one that's more affected in Alzheimer's disease, and norepinephrine, all have certain pathways in the brain, but you can see there's a lot of overlap as well. Again, those functions all work together to provide deficits in memory and other cognitive abilities. We know that even though you talk about dopamine in the treatment of Parkinson's, and that the primary dysfunction is in the destruction of the dopaminergic cells in the substantia nigra, that as we treat the disease, as you go to a neurologist and they try to start you on these levodopa medicines and manipulation of that system so you can make more dopamine, there's actually an imbalance between the dopamine system and the acetylcholine system. So once you start treating it, you have that initial dopamine loss, and then you start treating it. That actually isn't all just about dopamine. It's also affecting your acetylcholine. And acetylcholine affects memory, and it also affects smooth muscle control in your body. So things like sweating and constipation and all those things that involve muscles are also controlled by acetylcholine. So there's a very significant balance that you have to undergo. When we're doing that to treat our physical symptoms, sometimes the imbalance actually affects our cognitive system. And so if you've got too much dopamine or too much acetylcholine, you can get different problems in the brain. And down here, I've got this curve in this greenish yellow, which we call the Yerkes-Dodson curve, and it's an inverted U. And what it tells us is that at low doses of these neurotransmitters, you actually perform just as poorly as you do at high doses of those neurotransmitters. So it's not about just flooding the brain with those neurotransmitters. You have to be right in the middle at the optimal point in the curve in order to have optimal cognition, which includes memory, focused attention, good judgment. Because when you don't have enough of it, you can be distracted, impulsive, hyperactive. And when you have too much of it, you can have the same thing. And so it's really important to get yourself on that appropriate part in the curve. Common cognitive symptoms in Parkinson's disease include things like slow thinking and reaction time. That's your mental metronome. So we're all used to taking in information and spitting an answer back out at a certain rate. In Parkinson's disease, that changes, but nothing tells us that it changes. And when we try to process information at the same speed, we wind up losing a lot of it. A lot of it falls through the sieve. We say, well, I don't remember that. And sometimes that can be fixed by learning a new speed, learning a new cognitive metronome. Visual impairments. So the parts of the brain that process that information, not the eye, but due to the brain. Memory impairments. In Parkinson's disease, it's less about totally forgetting the information, but more about having difficulty retrieving it and difficulty with those executive processes, planning, retrieving, inhibiting. You know, if you can't inhibit external information that's not involved, you can't pick out the good information. Depression, I told you mood. Depression sinks our cognitive resources. And if we're feeling bad, we're not going to be able to remember as efficiently. It's one of the most common problems in depression. And depression is very treatable. So 20 to 40% of individuals with Parkinson's are within the accepted range that we consider clinical depression. And as a matter of fact, some people, while these cells in the substantia nigra are slowly dying, they can have significant depressive experiences for 10 years before they have the actual onset of the clinical disease. And so part of this is very much associated with noticing what the progression of these symptoms are. Again, apathy is another part of Parkinson's. Apathy is considered separate from depression. It can also affect your memory because you're not motivated to do things. And it's important to understand how that's different from clinical depression. The onset of these symptoms, and this is a complicated graph and a complicated chart, but you can see that early on, right, you get a lot of these kind of more mood and sleep problems. As the disease process progresses, you start to get the clinical syndrome that brings you to the neurologist and gets you a diagnosis and you get put on medicine. But as it progresses, you get these more complicated symptoms like dyskinesias. You start going on, levodopa, it controls your tremor. Later on, you start getting uncontrolled movements that likely represent that disbalance between dopamine and acetylcholine. And you may also notice cognitive symptoms that are associated with those things. When patients are newly diagnosed, remember at that point, you've probably had this process going underlying for several years, but there have been studies that look at newly diagnosed, and those individuals have most impairments in the attention and executive functions, not in memory. And this is very different from Alzheimer's disease, where that is the presenting problem. But individuals with Parkinson's have most difficulty with mental flexibility and with attention. That affects your memory, but it's not a primary memory deficit, right? And so as individuals go on, we know that about a third of patients with Parkinson's disease go on to present with prominent memory difficulties, prominent memory problems. And you can see in this graph that we talk about preclinical, and a lot of people will stay in that range. Some people will move on to this diagnosis we call mild cognitive impairment. And it's really it's kind of a silly diagnosis, but it's a grab bag that just means there are cognitive changes that you notice and that your family notice, but that overall you're able to do the things you need to do, pay your bills, remember the news, take your own medicine, all those kinds of things. Once you're not able to do those things anymore, that's when we consider it a dementia. So, we've kind of got normal Parkinson's memory problems, mild cognitive impairment, which is usually difficulty with attention and processing speed and flexibility, and then the dementia process. Most people with Parkinson's don't progress to this dementia stage, whereas people with Alzheimer's disease do. The mild cognitive impairment is present in, the range 20 to 50%. And the executive attention disorder seems to be most common. Not necessarily that you forget or that there's destruction of your memory, you just have difficulty accessing those memories. When we talk about dementia, a lot of people are confused about what is dementia? What's Alzheimer's? What's Alzheimer's dementia? What are these dementias? Dementia simply means your cognitive abilities, your thinking process isn't strong enough to handle your day-to-day functions. You can't get dressed, pay your bills, make sure that nobody's asking you for money when they shouldn't, remembering how to drive, remembering how to get places. Once you can't do those things, your cognitive abilities aren't able to sustain independence, and we consider that dementia. That can happen in Parkinson's disease, and we call that Parkinson's disease dementia. There are about 170 known causes of dementia. The most common is Alzheimer's disease. People who have Parkinson's can get Alzheimer's disease on top of that. The biggest risk factor for Alzheimer's disease is old age, but it's not common. It doesn't give you greater susceptibility to Alzheimer's just because you have Parkinson's. But in those individuals who progressed to the point in Parkinson's where they can't handle their functions anymore, their mental functions, we do see impaired memory, impaired ability to find your memories, poor problem solving, poor task planning and sequences, and really bad attentional impairment. And we see that again over time. The numbers range from 30 to 60%, 1 to 2/3, but it really seems to be on the lower end unless people are living into very old age, at which point there's an overlap between normal senility and that age group as well. Again, it is not Alzheimer's disease. And you can see the features of Alzheimer's: memory decline, later in the disease, you get psychoses. It's a very different disease process in Parkinson's disease. But it is related to Lewy body dementia. And as a last kind of slide to my talk, I just wanted to point out that in Lewy body dementia, it's the same process, we think, as in Parkinson's disease. It's just that it's a more severe and quick deposition of alpha-synuclein and these Lewy bodies, and they form around the cortex of the brain, that outer part of the brain that does all the thinking, whereas in Parkinson's, it tends to stay down in the brainstem for a long time before forming out. And so the process is more rapid and more aggressive, and that's why we diagnose Lewy body disease if all these things kind of happen within the same year, and if they're kind of spread out over years in the context of established Parkinson's disease, we tend to consider that Parkinson's disease with potential exacerbation to dementia. And so I've gone a little bit, 2 minutes over time, but I wanted to thank everyone for listening and for joining me today. And I hope that maybe listening to this talk and reviewing some of the information will help you with some of the questions you may have had about memory in Parkinson's. And don't forget, it's related to not only the disease, but age, your medicines you're on, and things like depression, and some of that is very treatable. So if you're having memory problems, make sure you talk to your doctor about it, and we can figure out what that's due to and get you help for that. Thanks very much.